Hi, Junaid again with the Acute Ischemic Stroke 2019 Guidelines Review. In this section, we're going to discuss hospital systems of care. I'm very glad that VMed decided to support this educational activity, not for just their clients, but for everyone. In this, as we discussed last time, the guidelines are divided into 6 different sections. This is the first of the section. And in this particular lecture, we're going to discuss the first 3 points: pre-hospital systems, EMS, and EMS systems. So just to understand that from the pre-hospital system perspective, there are a few guidelines that are actually important to understand. Number 1, public education programs. The level of evidence is low. Clearly, nobody can really study that effectively, but for sure, class of recommendation is high. Everyone should be educated on symptoms and signs of stroke, including Uber drivers, high school attendants, shopping mall attendants, mall security, etc., etc. Anyone that is technically in a public sphere can identify a person who's having a stroke should be educated on it. And there's definitely significant support from the authors as a high class of recommendation. The second important thing is to call 911. It is extremely important that they do call 911, as there are systems in place in practically most states and now counties where you can place 2 IVs within the ambulance. You can actually get the blood sugars. You can actually get the EKG. So calling 911 is more important than driving yourself to the emergency room. So it's important that people are educated on that portion as well. And then lastly, the patient or other members should activate 911, as it says. All 3 systems is important that we publicly educate people for the signs and symptoms of stroke and calling 911 right away. Stroke assessment by EMS. That is basically a point of contention for some people, but at the end of the day, the class of recommendation still remains 1, and provide pre-hospital notification, that's also 1. So let's discuss one at a time. So stroke screening tool, the word screening tool is very important, and we're going to get into that. The thing that I wanted to point out over here is that if you look at the level of evidence, it's not there. And it's actually B, or less, actually lower form of B. At the end of the day, do we really have that much good evidence that support this recommendation? No. But the more important thing, as we're going to come in the next slide and further discussion about screening tools, you would understand why it is important, and therefore the class of recommendation is extremely high. That is 1. So if you are a stroke director, if you are actually in public health policy, you should consider to make sure at a point that stroke assessment tools are being taught to all the EMS responders, and they're using it on a standardized, consistent way. And we'll come to the word standardization as well. And of course, pre-hospital notification. There are multiple apps. There's a new app just launched called Join Triage app, or their Pulse app, etc., that actually pre-notify and even can send an EKG to the receiving emergency room. These are all great systems. People should enhance them, should integrate them through their hospital systems, and class of recommendation also supports it. Now, EMS systems is concerned, what we really need to do is create regional stroke systems of care. And it is extremely important. In this situation, there is evidence to support that. So what the idea behind is that, and to be honest with you, there are now approximately 22 states that have already implemented this, and there are a few states that are coming on board. I think the last state that I was looking at the news for was Wisconsin, that is trying to get on board with this sort of regional systems of care. And the idea behind is that we want to take care of the patient and not hospital branding. So if EMS has an exclusive contract, for example, with some particular hospital system, they should not follow that contract per se. And if the patient has a stroke, you should go to the nearest hospital. And if the patient is suspected to have a large vessel occlusion, and in these situations, should you take it to Mothership or should you do drip and ship? All these should be decided in the sense like these things should be decided right away before these things are going. So if the patient is having a stroke, should you take it to the comprehensive stroke center, the Mothership, or the primary center, that is actually the local hospital in the ER where they can drip and ship the patients? Again, there's a discussion, there's no high evidence, and we're going to discuss that as well. At the end of the day, the important thing is to understand is to have a proper guidelines at the local level, and there should be a regional system in which all experts from different hospital brands and systems work together for the benefit of the patient. The second thing is rapidly identifying of the stroke and using a standardized tool for screening. 2 problems. Number 1, as you can see, the level of evidence is B and R. The the issue really is that, number one, there's really not a good screening tool. And I'm going to come to that in a minute. But the word here is not just screening tool. The word here is standardized screening tool. What tool? Any tool. It doesn't matter. What is important in this situation is that you have standardization of a screening tool. So EMS in the whole county or the state level is using one system. And then you know that if the patient has declined, then you probably have that particular scale used. And therefore you can see worsening or improvement for that matter, and that will change the management of that patient particularly. And more importantly, when you are communicating in a standardized fashion, everyone knows what to expect. So in that situation, it is very important that we use standardized screening tools as compared to different tools by different EMS from different hospitals, etc. So regional systems of stroke care definitely defines need for standardized tools for screening of stroke. Now, the problem really is the big question is Mothership versus drip and chip, and I'm going to come to that in a minute. Should you actually bypass? The level of evidence is not there, nor is the class of recommendation. So it is really uncertain at the moment if you should bypass primary care center if you suspect a large vessel occlusion. That's the big problem, suspect the large vessel occlusion, because there is really no good way to actually identify clinically 100% specificity with very reasonable specificity. It's never going to be 100%, but the question is with very reasonable specificity that the patient should bypass and then go to a primary care center. And then if the more important thing is, let's say if the patient does not have go to a comprehensive center and the patient goes to a primary care center. And let's see if the patient is actually at the primary stroke center and needs to go to a stroke center, comprehensive stroke center. Rapid transportation systems should be adopted, should be standardized, should be taken into account. And then again, the level of evidence is not there, so it's basically an expert opinion. But the class of recommendation is slightly higher, and therefore, at least in my opinion, I think this should be a higher class from the get-go. And the reason behind it is that if you are able to have standardized ways and also prioritizing transportation as soon as possible, you're going to save patients' neurons, which by definition can save a life or a limb. So now let's come to, this is the real problem, the Mothership versus drip and chip. And this was recently studied, I think in 2019, and as you can see, it's actually referenced at the bottom. The data is not that strong. First of all, the study has significant limitations. It's a retrospective study. It doesn't really have a real amount of power. To be honest with you, can you ever do a blind randomized control trial? I don't think so, because this would really be unethical in my opinion to do such a kind of study. So we need a large amounts of retrospective data to prove this concept. However, either way, if you take it to the Mothership, it has a trend towards better outcome, but it's not significant for the level of evidence to change and for the class of recommendation to change. So, and there are good reasons for it. And then one of the things is that, sometimes the comprehensive stroke center is miles away. So you have to get the patient to the primary stroke center, and they might have to be flown to the comprehensive stroke center. So it is important in your locality, in your regional systems of stroke care, you understand how many rural areas you are supporting, how many urban areas you're supporting, how many comprehensive stroke centers do you have, and in that system you need to identify where the patient should actually get to drip and chip or should go directly to the Mothership. And those are questions that you need to answer depending on the distance, traffic, time of the day, etc., etc. So all these things need to be considered. But clearly there is trend towards benefit. Again, there is no strong level of evidence here. Now let's come to the screening tool. This is a fantastic study that was done back in 2016 that identified 18 papers and 3 conference abstracts. And it identified about 7 screening tools. And at that point in time, and of course since then I can count at least 10 more. Everyone at any place is trying to do a retrospective analysis to see what kind of new screening tool they can come up with. And the reason behind that is that, what we all want to do is to identify a large vessel occlusion through clinical ground so we can move the patient, transfer the patient from primary stroke to comprehensive stroke right away, or decide on imaging right away. For example, the patient needs a CT angiogram right away or not. These things are great in theory, but unfortunately the biggest problem with all these screening tools is that it is clearly not the best in terms of screening tools is concerned. Most of them have higher sensitivity. Now, defining sensitivity. SNOT, S-N-O-T, sensitivity rules out the patient. So the sensitivity of these tools are reasonable. I mean, CPSS and FAST has the highest sensitivity, but at the end of the day, the key issue over here is that they're great at ruling out the patient, but they're not good at ruling in the patient. And these truly were initially designed to be ruling in stroke, not really large vessel occlusions, and we are potentially overburdening these screening tools for looking at large vessel occlusions. So it's very important to understand that screening tool has their own biases and limitations. And screening by definition is supposed to be before the actual test. And the idea behind that is that you can actually rule out the patient so that you can actually, there's a smaller circle of patients that you have to truly test with the next sort of test in the line to actually do that. So important thing to understand about screening tools is use standardized, consistent delivery of these tools, but understand its limitations. So in conclusion of that particular study, there is no recommendation for using one particular screening standardization tool, but use one, whatever you decide, and it doesn't matter which one you decide. As long as it has reasonable amount of sensitivity, use it. The accuracy of prediction instruments for diagnosing of large vessels occlusion. This is a study that was back and done in 2018. And then what it concluded that is that there is no scale that predicts large vessel occlusion with high sensitivity or high specificity. So at this point in time, what we are always wondering is there one tool that's going to be helpful? Actually, no. And then most of these studies have been done on retrospective studies, and then there's no true prospective study that is done in which patients, providers have been properly trained to perform these tools. So if you have to decide on one tool, it's at the end of the day, it's an AIS-stroke scale. And even in an AIS-stroke scale, if you look at the sensitivity and the specificity is about the 75% range, it's not 100%. At the end of the day, the large vessel occlusion, by diagnosis, you need to see the large vessel occluded. So that means that it is a radiological diagnosis. And at that point in time, what you're looking at is basically MRAs and CTAs. And this study was kind enough to actually tell us that CTAs are better than MRAs, which again, depending on your situation at your place, you can decide how you want to address that. But at the end of the day, you want to use an actual radiological study to actually confirm large vessel occlusion. To predict large vessel occlusion, the best tool is an AIS-stroke scale. So let's not discuss too much time on screening tools. At the end of the day, that's not designed as a tool to actually predict large vessel occlusion. And the best tool that we have, an AIS-stroke scale, which is very hard to administer. It takes time to administer. It still has inter-rater reliability, but it is 4 points. So you have to understand its limitations as well. So in my opinion, at the end of the day, if you look at all the mechanical thrombectomy trials, that's where the occlusion is, that's where you're going to decide if you're going to do a thrombectomy. None of them relied on these sensitive screening tools. They all required CT angiogram and MRAs for diagnosis. And there's a reason why they didn't rely on all these, CT angiograms, etc. for decision. And they did not rely on just even the AIS-stroke scale. So please use the screening tools in a consistent, confirmed, standardized way. However, know its limitations. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.